Going to be given by Ajay Kurtne, who is Professor of Medicine at Columbia University and the head of the cath lab. Ajay.
Well, thanks so much. It's just a real pleasure to be here in person, and thanks for the invitation. I'm charged with talking about the PA catheter, and I think many people believe in it, many people know how useful it can be. And I was asked to speak about whether it's always necessary, and I'm generally going to say yes, but I also have a rule, and that is never say always for anything in the cath lab or otherwise. And so hopefully I'll give you a little bit of perspective on this. I just want to thank Rashad Garan, Justin Freed, Neer, the rest of the Columbia Shock team for many of the concepts, slides, and beyond in how we formulate this. So to start off with, I don't have to tell this audience, but it is worth thinking about what exactly the PA catheter tells us. They're direct measurements that we can ascertain both during insertion and then serially over time, and this concept of serial observation is really one that I want to hammer home. We can also get calculated data based upon these numbers, and they tell us a bunch of different things. And even beyond this, you can use simulation and the like to get things like stress blood volume and all kinds of other measurements to be able to manage patients. But that's the nitty-gritty of what's being told to you, and the real question clinically, though, are these. And you want to first be able to identify, is this shock, is this not shock? What's the etiology of shock? Is it a GI bleeding patient who's hypotensive and happens to have heart failure, or is the patient truly in shock? You want to then determine what the type of issue is it. Is it a volume issue? Is it an output issue? And even what side, right or left? And then finally, the key thing is what to do next. Volume, pressors, MCS, and other things that you can do. And the problem with the PA line by itself is that those last two things, and even the cognitive component of it, is not what the catheter tells you. It gives you a bunch of numbers, and you have to use your brain and be a good clinician to be able to figure out what to do. And that's a really, really fundamental point about how to use PA catheters. It is important to talk about downsides, because there are downsides. There's time, there's effort, there's cost to it, not just with the insertion, but the maintenance. If you keep it in for too long and the patient develops a line infection, that's a problem. The data is often misinterpreted or misleading or simply not used if you don't have a good program and an ability to educate people on how to use this appropriately. At times it can be redundant to things like a CVP plus an echo in a more simplified patient, and then additionally complications like the ones I mentioned are important. So yet, why do we insist upon a PA catheter? Well, the reason is as good clinicians, we have to take the good with the bad, minimize the bad, and maximize the good. And I do think that because of some of these issues and some of the data, we're seeing a decline across the board in PA catheter use, although in this JAMA Cardiology paper, you do see that for heart failure patients, there's an inflection point and it starts to come back up again. You'll recall that in 2005 was when the ESCAPE trial was actually published. The other thing I want to talk about a little bit in terms of a downside is that sometimes house staff education these days, you have lists, you have checkboxes, you have to do the EHR and everything, and on the checkbox list is put in a PA catheter. Box is checked, the PA catheter was put in, I did my job. Well, no, that's not enough. You have to know what to do with the data once the catheter is put in to be able to then manage the patient. And I think there are some prospective data that show that if you put these catheters in patients that don't necessarily need them, you're not going to get a benefit from these catheters. And that was shown in the ESCAPE trial. These were not shock patients, importantly. But for some patients with decompensated heart failure at a variety of stages that are not that severe, you might be able to manage these patients without a PA catheter. The question is, if the patient's in shock, can you do it well? And the downside of not putting it in, because these patients have so little reserve, and if you make the wrong decision, they decompensate to death as opposed to something recoverable, that's the real issue that we need to talk about. So in terms of how do we optimize patients' hemodynamics, we've had some great talks leading up to this, and I think this issue of serial observation, this issue of being a good doctor and interpreting data in the context of other data and integrating a formulation for the patient are really essential. You got to keep calm, you have to check, and recheck again, see how patients are doing. That case we heard presented earlier by Dr. Owen, as I said, what we would typically do in that case is we would make an adjustment, keep the patient in the lab, see if what we did made a difference, and then maybe obviate the need for a device and then determine if things were going well. The problem is if you don't integrate these numbers into the clinical picture, you might end up with a scenario where you give somebody, in that case, on cocaine, an agent like an inotrope and perhaps induce VT, and then in some cases blame the patient's substrate instead of blaming oneself for making the wrong decision in terms of what to give that patient. So these are the really critical components of it. You can overreact to numbers and overreact to them in a deleterious fashion. The trends are usually more useful than single point measurements. I'm not going to go through much of these data other than to say that in the sickest patients, when you see a therapy that's invasive starting to demonstrate a benefit in observational data, that's actually a pretty powerful sign, because usually speaking, if you take sick people and you study the use of MCS in them or other things, you're always going to show worse outcomes because the patients were just more sick. So if you take an invasive intervention in a sick patient population like those in shock and show a benefit, there is probably a benefit there that needs to be determined in randomized trials. We know that if you compare Swan assessments of volume optimization and other things like cardiac index to clinical judgment, we actually do pretty poorly. And so this is a slide I borrowed from Rashad showing that there's a very poor correlation with your clinical assessment and what you get with a Swan, which is why the Swan can really help you. I think also you can determine device selection, you can determine things like whether you need to do more volume, more inotropy and the like, and similarly you can look at not just the left side, but you can look at both sides and determine that in a significant proportion of patients there's actually biventricular congestion. Finally, identifying RV dysfunction is something that's emerging, and I'm sure we'll have some discussion about that. And ultimately, we talked a little bit about weaning protocols, but this can be really, really useful to determine weaning. But you can't hold your hat to the numbers alone, because if you do, you're not going to wean patients who are absolutely weanable. You have to use this as a tool in the clinical armamentarium as a whole. We will talk a little bit maybe in the discussion about the need for a randomized trial and what the cardiogenic shock working group is planning. This is a trial that has the potential for failure if it's not done right, not just putting the Swan in, but what do you do after you put the Swan in really needs to be optimized and regularized within the study. I just want to conclude with a talk, a little history, because I was fortunate enough to be sitting in the audience when James Forrester was presenting at TCT in 2019, and he talked about the development of the Swan. And the reason I'm presenting this is I think it shows a little bit of an allegory to how we ought to manage patients, because it shows that, especially with the Swan, there's some trials and tribulations, there are things we can overcome and ways to get better. I don't know if you know, but Swan was sitting on the beach and saw sailboats and sort of thought maybe if he used a balloon-tip catheter, that could somehow enable this device to go into the PA or otherwise, or just at least to float in that way. As a favor, folks from Edwards actually put on a infant feeding tube, a balloon, and gave it to them. And what they basically did, and this was the first animal catheterization by Diamond and Forrester in 1969, where they put the catheter in and they saw this waveform and they realized it was maybe the PA. And in those days, there was no IRB, there was nothing like that. And so what they actually did is they sterilized the catheter, went to their medical ICU, and did it in a patient. I mean, it's literally unbelievable, but the story is amazing. And so they did this, and sure enough, what happened? The patient actually had a horrific run of VT because the catheter looked like the one on the left, not the one on the right, which was the modification to put the balloon to the tip so that it would perhaps be a little bit more stable. But that's exactly what can happen if you're trying to figure out in a really sick patient what's going on with the patient. You say, I'm going to do a Swan, I'm going to figure this information out. You can cause a complication when you do it. You have to persevere and figure out, okay, how do I avoid the complication? What's the downside, and how can I do it more safely? It also turns out that in terms of getting cardiac output, that required a collaboration, and somebody who fled from communism, Willie Gans, who actually abandoned all his worldly possessions, came with philanthropy to the United States, and had actually basically showed up at the same cath lab and through serendipity came up with a way to measure cardiac output through thermistors. So you have this collaboration, you're talking with your heart failure colleagues, your surgical colleagues, everybody's coming together to take care of a sick patient. And this story of the Swan in some ways is very similar to how we have to manage these patients. It's individualized care of these patients. This is how the Swan actually came about, how hemodynamic profiling came about back then. We don't want to throw this sort of thing away. We don't want to throw the history away, the collaboration away, but we do need to recognize that one size does not fit all with this, and we have to be good clinicians to be able to take care of our patients. Thanks so much.
Thanks, Ajay. Maybe I could just start with a question. How many people would randomize a patient in shock to get a catheter or not get a catheter, a Swan catheter? Let's poll. Nir, would you randomize?
No, for me, I'm already cardiogenic shock.
Difficult.
Maya?
No.
No. Would not randomize?
I would, because I believe that sometimes central venous pressure plus a good use of echocardiogram can help a lot.
Right.
So at least in patient with the cardiogenic shock, with a clear etiology where you see a rapid change in the clinical condition, you can wait before put a pulmonary artery catheter, in my view.
Marv, you would not randomize?
I wouldn't, but I'm actually listening to your point.
Right.
I think in today's world, where you have all these fancy echo techniques and instant things like that, that only with that addition.
So you can have CVP, you can have
Right.
echo.
It might be useful, but otherwise I'd say no. Because, the case example, your CVP's up here, you think
Right.
there's no congestion.
And clinical acumen is
But
not.
Dan, I
Right.
don't think
Depends
it's
on
a
the
fair
clinical
question.
acumen.
I don't think it's a fair question because not all studies was built to all centers. Meaning, IJ and I are very fortunate. We are in a center that is heavily ready to deal with cardiogenic shock. All the people that sit here. So for us, Swan is part of our daily life. But the reality, and I just saw the slide, is that most center in the United States doesn't
Right.
have it.
Correct.
And
They-
the reality...
They have it, but they don't use it, and they don't teach how to use it.
But in reality, they don't have it because they don't know what to do with it. So this study is an important study. Just the question that you ask is, Nir, would you randomize? Me, my center, no. Finn, in his center, no. Maya, in her center, no. But if you will ask Maya in another center in rural Indiana, maybe it will be yes. And if you ask me in an upstate New York center, maybe it will be yes. And I think that's the main thing, because bottom line, and I just saw this slide, and I went to Dan and I commented about this slide. The slide that you saw from Narang that showed the physical exam with the Swan, that actually the correlation was 50%. Flip a coin, you're congested, you're not congested, you're in shock, not in shock. We need to be honest to ourselves. The art of physical exam, like Osler developed, is gone. Okay, we are very good doctor. We're probably better doctor. People survive toughest people, but we are not as good in physical exam, and that's the reason we need objective number. And Marvin, to your point, if you will give me a tool that will give all the information from a Swan in a non-invasive, fine with me. I just need information that is objective, quantitative, and actionable.
Exactly
But
right.
here is about randomization, right? Look at the ESCAPE trial, perfectly randomized, controlled prospective trial. If you read the inclusion and exclusion criteria, if the physician felt that Swan
Yes.
would be essential for the management, the patients were excluded.
Yes.
That's
So
how
they-
you get fake results
Right,
in
so by definition-
in perfectly designed trials.
By definition, you excluded patients who
Exclude
don't
the
need
very
it.
subset in whom it may
You
work.
only
Right.
include patients who don't need it.
Right.
That's what it-
And
The only thing I fully agree with you, but the only thing I'll push back a little bit about is that we always do this. In cardiologists, we do this, interventionalists, like, any patient who was deemed a surgical candidate was excluded, or the physicians felt they had to be treated by surgery was excluded. The reason that's in there, though, in the protocol is you can't randomize with equipoise somebody who you know would benefit from one thing or
Who you
another.
think.
The way I interpret it, though, is if you put swans in people that don't necessarily need them, you're not going to show a benefit.
That's what it was.
and by the way, if Dr. Swan stayed in communist Prague, we would probably never have the catheter.
Daniel?
Nice debate, but I think that one of the points which is a little bit missed is the fact that what do you do with the measurements you get? And so what is exactly the value of each of these, especially when you compare with less invasive or alternative techniques? And perhaps one of the most valuable value you may have is perhaps the pulmonary artery occluded pressure. But I think it's only in very dedicated situations. When you will have a patient on ECMO and to decide whether or not to unload these ventricles. So otherwise, in most cases, it will be cardiac output that will be driving your decisions and assessment of tissue perfusion by other ways, which are not related to the PA catheter itself. And so that's perhaps why people abandon the PA catheter over time, because indeed with alternative techniques, and especially echo as mentioned, you can have assessment of 95% of the measurement in a reliable way. And so this is perhaps the things we need to think at, in which conditions we really need to have the PA catheter, and in which conditions we may rely on the alternative techniques to have good medicine done in these patients.
I think a good thought experiment that I encourage all of our house staff when I rotate through the CCU to do is decide in your mind or think in your mind, even write down, what do I think is going on and what am I going to do before you put the Swan in? And then put the Swan in and see how frequently it changes. And I think for all of us on the panel, it's changed enough times that we've recognized the value of the device. But it's still important to do it because there are patient times when you think that you're going to do something and you probably would have done the same thing anyway, and those are the cases on the margins.
IJ, in the paper that you mentioned from the RANG, actually this question was exist. What is the therapy you're going to give the patient? And then they got the number of the Swan. Would you change? 70% of the time, people change completely the management they choose to their patient.
One other thing to point out, Ajay, you showed the study from Rashad about the Swan from a cardiogenic shock working group. In the bottom right, there was a key part of this was that and now of course this is retrospective, so we have to take this a little bit, with a grain of salt, but Swan did not change outcome in Class B or C. It was in D and E where the utilization of Swan was shown to improve outcomes.
Yeah, and I think that for me, while observational data you always take with a grain of salt, the point I made before, which is that if you have an escalatory therapy that's used in sicker patients that demonstrates a benefit in those patients, observationally, that's more likely to be true than the opposite, which is just confounding by indication. You're putting in a device in a sicker patient, so if they do worse, of course they did worse because they were sicker. This is the opposite of that.
Yeah, so the D's and E's, these are the ones that are getting a lot of drugs and a lot of devices. Ali?
Point regarding randomizing patient in non-Swan users centers. Probably not fair for the trial because if you're going to start to put Swan on such kind of centers and they don't know how to deal with the data and how to deal with the Swan might be not fair for the Swan patient. We might get the same results we had in the past and say Swan is going to kill patient like we.
Yep.
No, you're 100% right. That's the challenge.
Yeah.
Like a center like you or me doesn't want to do it. A center that needs to do it doesn't know how to do it.
Yeah.
I mean, we need a lot more. Again, I think the point has been made that things have gone out of favor, and in earlier days, we used the Swan all the time. The key word is the dynamicity and the slope of illness. I think it was, I can't see with the lights, but maybe it was David Barrow, is that David? Who made the point about the fact that you need serial observation, and I sort of made the glib comment about duty hours. Well, we didn't have duty hours, and you could be at the bedside, watch the patient all the time. You could see, did you make a mistake or go in the wrong direction with the drugs? To put in a device and just leave it without utility is pointless. And I think that's the concept, that you have to be able to use it. And Swan is a dynamic thing. It's not just to be put in and forget it. So that's an important point.
Yeah, that post-call day was when you determined whether you did right or did wrong, and that was such a critical point of learning.
Great. Thank you, Ajay.